discussing recurrent UTIs with Dr. Ariel Moradzadeh, a board-certified urologist working at the Cedars-Sinai Medical Group in Beverly Hills, California. He received his medical degree from the David Geffen School of Medicine at UCLA, completed his residency at Cedars-Sinai, and fellowship at UCLA. In his practice, he has seen countless patients over the years who struggle with recurrent UTIs, and so he, along with his medical partners, have decided to create a unique new supplement specifically for this. So happy to have you today. Thanks for coming and being with
Thank
us.
you.
It's really
Thanks so much
exciting.
for the introduction, Marnie. I appreciate it. I'm really excited to be here today and to talk to you about recurrent urinary tract infections, prevention, and talk about our supplement.
Yeah. So why don't we just get started by talking about what causes recurring UTIs?
Yeah, sure. So there's kind of a bimodal distribution in what causes recurrent urinary tract infections. So it occurs in younger females that are sexually active and then older females that are postmenopausal. In the younger females, in the sexual active age range, it's really because the female's urethra is quite short compared to the urethral length in a male. In a female, the urethra is about 2 to 3 centimeters in length, and just the mechanical translocation that occurs during intercourse and the movement during intercourse causes bacteria to be pushed into the urethra and into the bladder. That's typically what causes what are called postcoital or urinary tract infections that occur after intercourse. And that's typically in younger premenopausal sexually active females. So in the older females, the postmenopausal or even perimenopausal females, what happens is there's a decline in estrogen levels after menopause. And what happens is the good bacteria in the vaginal canal is dependent upon the estrogen levels in the vaginal canal to essentially constitute good bacteria. So when there's a decline in total body estrogen, there's a decline in that pH balance in the vaginal canal, which leads to an overgrowth of bad bacteria. So the vaginal canal after menopause goes from being a acidic canal to a more alkaline canal, and that causes this overgrowth of bad bacteria and the loss of lactobacillus, which is kind of that good commensal bacteria that helps sustain a healthy vaginal canal and prevents bad bacteria from entering the bladder. So that's really the bimodal distribution in terms of younger females and older women who get recurrent urinary tract infections.
So what would be the best way to prevent UTIs in these groups?
Yeah, so for my premenopausal and postmenopausal women, I kind of have a different treatment algorithm. For both groups, I still recommend, cranberry extract, high in proanthocyanidins, D-mannose. There's this ingredient called pine bark, which was studied in France, recently published. The active ingredient in it is called pycnogenol. This is high in proanthocyanidins, which you find in concentrated cranberry extract as well. And these have been studied and shown to bind to bacteria to essentially prevent the bacteria from binding to the lining of the bladder. So by binding these molecules to the bacteria, you can essentially clear the bacteria from the urinary tract. So that's number one. Number two, I see a lot of patients, especially teachers, who hold their voiding intervals for long periods of time. And so, similar to a pond versus a river, a pond, when there's still water, you're going to get an overgrowth of bacteria. So you want to increase hydration and increase the cycling of your voids, maybe every hour and a half to 2 hours to make sure you're not holding on to urine. And then the other kind of treatments I go through is for younger sexually active females, I typically consider postcoital prophylaxis, which is kind of immediately in a window following intercourse. I found in some of my patients, it's also more helpful to take it before intercourse, maybe 30 minutes to an hour before. So it's in your bloodstream and the antibiotic is making its way into the urine to help fight off the bacteria. So pre or postcoital prophylaxis. In some patients, I also recommend just taking a daily low dose of antibiotics, like a daily low dose of macrodantin or just trimethoprim. And then another option, if someone doesn't want to take daily antibiotics or pre/postcoital antibiotics, then I recommend something like Hiprex or methenamine. This is a prescription medication. The kidneys will convert Hiprex into formaldehyde,
Hmm.
and it basically dumps formaldehyde in the urine, and formaldehyde is how they preserve bodies in the morgue. It basically makes it a hostile environment for bacteria to grow. And it's a safe medication, well tolerated. The only downside is they're quite large tablets, and you got to take them twice a day. But they work better if you acidify the urine. So I have patients also take a low dose of vitamin C in the morning with that. So that's mostly the premenopausal patients. Those are kind of the treatment regimens I recommend. And then in postmenopausal women, it's really about reconstituting that natural estrogen level in the vaginal canal. And for those patients, I really recommend using like a vaginal estrogen cream, such as estrace. There's Premarin, using it 2 to 3 times a week, typically around the opening of the urethra, to help reconstitute the good bacteria around the opening of the urethra, the lactobacillus, to then help prevent these recurrent infections.
Mhm. Okay, that's great. That's great information. Thank you. So, what would you say is the difference between treating a one-time UTI and managing recurrent UTIs?
Yeah, so the one-off UTIs you can typically treat with a couple days of antibiotics, whether it's macrobid, Keflex, fosfomycin, Bactrim. Those are kind of the first-line antibiotic options. Um, as opposed to patients who get recurrent infections, the American Urologic Association definition of recurrent UTIs is 2 UTIs within 6 months or 3 UTIs within a year. So for those patients, the plan of treatment and long-term management kind of goes back to what I talked about earlier with, some supplements, potentially pre or postcoital prophylactic antibiotics or a daily low-dose antibiotic, or Hiprex methenamine, as opposed to, postmenopausal women that get recurrent infections. Then it's really having this discussion about a daily low dose antibiotic or Hiprex, or most importantly, is really the estrogen effects
Mhm.
of using that cream in the introitus or in the vaginal canal around the urethra about 2 to 3 times a week.
So, and what about the overuse of antibiotics? So, I know a lot of people, especially when being diagnosed with people who get it eventually diagnosed with interstitial cystitis, are put on multiple antibiotics over a period of a year to 18 months. So, what would you say is detrimental to someone's health, being put on multiple antibiotics, or even taking that low dose antibiotic over the course of a period of time, like 12 months to 18 months, or even 2 years?
Yeah, so there is always the concern of antibiotic resistance, right?
Yeah.
If you're getting multiple rounds of different antibiotics, you're essentially self-selecting the ones that are resistant to the antibiotics you were previously on. So, that becomes a slippery slope because you're self-selecting for the bacteria that actually survive those prior rounds of antibiotics. Now, when it comes to daily low dose of, let's say, macrodantin or trimethoprim,
Mhm.
they're usually pretty well tolerated, and bacteria don't readily form resistance to things like macrodantin or trimethoprim.
Mhm.
So those are typically the antibiotics of choice when selecting for kind of the daily antibiotic regimen. The thing that I still caution patients is there is a possibility of selecting the resistant bacteria, and when you take an antibiotic, you're essentially changing the milieu of the GI tract even.
Mhm.
As these antibiotics are ingested, obviously you're changing, the good bacteria and the milieu in the GI tract. So those are things to really consider and take into account when making these kinds of decisions.
Mhm. So, how do probiotics or other natural supplements play a role in managing recurrent UTIs? Would you say, a lot of people come to you and say, I'd rather go the natural route, especially when they've been on antibiotics so many times within a short period?
Yeah, absolutely. So um, there are there is a role for probiotics, both oral probiotics, intravaginal probiotics.
Mhm.
They help essentially reconstitute the good bacterial milieu in the GI tract and the vaginal canal and so forth. In addition, I have a lot of patients that ask to avoid antibiotics altogether, or they prefer not to take postcoital antibiotics or daily antibiotics. For those patients, I have found it helpful to use supplements, such as Eurodefend. There's a lot of different supplements on the market, but things that you want to make sure you have: high dose cranberry extract that has high proanthocyanidins,
Mhm.
um, at least 36 milligrams of proanthocyanidins, and then D-mannose. So D-mannose is a sugar derivative, and these both in conjunction with something called pine bark, which I mentioned earlier, which has that pycnogenol. These bind to the bacteria and essentially help you clear the bacteria from the urinary tract. So another thing I like to tell patients is dilution is the solution to pollution. So you want to drink more water, stay well hydrated, void every hour and a half to 2 hours so you're not sitting there with a full bladder, allowing the bacteria a chance to replicate and multiply. So I find that those kinds of tips are helpful. It's been pretty much debunked. They say wipe front to back, etc. Those things don't necessarily work, or wear cotton underwear, breathable underwear, things like that. That's been pretty much debunked as not being something that works or is helpful.
Mhm. So you have a lot of patients who probably say, "No, I don't want to be on antibiotics long term." So is that why you decided to create this supplement?
Yeah, so that was part of it for sure. I mean, I was getting so my background, I'm a urologist, board certified urologist. I did subspecialty fellowship training in men's health and male infertility. But when I first started in practice, I was seeing so many females in my practice for recurrent UTIs
Mhm,
every single day. And I said, look, I'm a urologist. I know how to take care of you. I know how to treat you. But let's find a way to prevent you, or like minimize the number of visits you need to make to a urologist. So this really led me down the rabbit hole of learning what's on the market, doing all the research to figure out what ingredients are key that you can put in an all natural supplement, finding a manufacturer to be able to source the ingredients that I'm looking for, and then create a product. So that was really the motivation and the nidus for creating the supplement. And my goal was to really help all these patients to, number one, avoid them needing to take so many rounds of antibiotics, and then number two, keep them out of the urologist's office. Not that I don't want to see them. I love all my patients, want to take care of as many people as I can, but it's really, how can I save you from needing to come in?
mhm, mhm. And does it help men as well?
Yeah, I have quite a few men or male patients that take Urodefend for the
Mhm,
same reasons, recurrent urinary tract infections or bacteria in the urine, even though they don't have a necessarily symptomatic infection. Just when they come in for routine urinalysis, if I find bacteria, it's not a bad idea to recommend them to take it. The only subset of patients that I advise, not against taking things that have D-mannose, but just a word of caution, is that D-mannose is a sugar derivative,
mhm,
and so it can make it slightly more challenging to manage one's blood sugar if they're
mhm,
diabetics and they take a D-mannose. So it's just something I say, you can take it, just be mindful you may need to up your insulin dose or make the
mhm.
necessary adjustments therefore afterward.
For sure. So how did you pick your ingredients for your specific supplement? And is there research to back your supplement?
Yeah, yeah, absolutely. So I went through PubMed, looked at what data is available, found that cranberry extract is something that's super important, obviously. Looked at the solubility, and you need the max soluble concentration of proanthocyanidins is about 36 milligrams. So any additional dose of that essentially is a waste or unnecessary. So we said, okay, we're going to at least have 36 milligrams of PACs or proanthocyanidins in our product. Did a bunch of research on D-mannose as well. And then there was a study I read out of France looking at pycnogenol or pine bark extract as a means of UTI prevention and prophylaxis. And so based off of the studies that I looked at and the data that I analyzed, I said, okay, these are the three key ingredients we need. And then lastly, vitamin C, which helps to acidify the urine to help make essentially all the ingredients work more effectively in preventing urinary tract infections. So that
Mhm.
was really the motivation behind coming up with the Eurodefend.
Because I don't think I remember originally you told me about the pine bark extract, and I had never heard that before. So it seems like not you don't find a lot of supplements that contain pine bark extract. So that's what I
Right.
would say really makes your supplement unique because it
Correct. Yeah.
includes that. Yeah, which is great.
Thank
Um,
you.
So, can recurrent UTIs lead to long-term complications if left untreated?
They can. So recurrent UTIs can lead to a couple problems. You can get an ascension of bacteria. So bacteria from the bladder can make its way up to the kidneys. You can get a kidney infection
Mhm.
called pyelonephritis. You can also get a urinary tract infection, getting the bacteria getting into the bloodstream. That's called sepsis. That can be
Mhm.
almost, it could be fatal if left
Mhm.
untreated. So a simple urinary tract infection can potentially escalate and turn into something more serious. So it is important to make sure that prevention is key, and also once a patient develops a urinary tract infection, to definitely make sure they're being treated for it appropriately.
Okay. Yeah, because I feel like there have been people in my life who I know, they ended up specifically a male patient who in their 70s who was experiencing symptoms that like high fever, just didn't feel well, no actual urinary tract issues, like no
Hmm.
issues with peeing, no burning, stinging, frequency, nothing like that, just a really, really high fever. And then I remember saying, when he was at the ER finally after waiting quite a while, saying,
Hmm.
make sure they do a urine sample. And that's what he had. He had a urinary tract infection and he was close to going into sepsis. So,
Wow.
yeah, it can be super dangerous. And I feel like a lot of people don't know that. A lot of people don't know, and that's the first thing I feel like GPs should check for, right? Is
Totally.
urine,
And
especially in older men.
100%. And not even, to your point, but not even in older men.
Mhm.
In older patients, urinary tract infections often present with altered mental status.
Mhm.
Yeah, an acute change in an elderly female or male's baseline cognitive function or performance can
Mhm.
be a tip off that maybe they have a urinary tract infection. And it can present with psychiatric presentations, it can present with just more combative behavior or confusion, lethargy, somnolence, difficult with arousability. Those can all be a tip off that an elderly loved one may be having a urinary tract infection.
Mhm. And what would you say would be best for like, is it useful for these people to take a daily supplement to try to
Yeah.
prevent themselves from getting
So,
into
yeah,
this
it can be
situation?
useful. Yeah, obviously, like, I'm a urologist. I also am a huge proponent of taking supplements. Obviously, supplements are not for every patient,
Mhm.
but by and large, I find that especially something like ours, Eurodefen, all natural ingredients. The only real patient population that you have to be somewhat careful with are diabetics, because the D-mannose can alter their
Yeah.
sugar control. But for the most part, I mean, supplements, if they're all natural, no additives, no added ingredients aside from what's listed, they're
Mhm.
safe to take. It's like taking vitamins. There's no allergic reaction to be concerned about and things like that. So
Mhm.
um, I think more patients can be on supplements. And then for the elderly patient, especially the elderly gentleman, making sure they're seeing a urologist to make sure they're not retaining urine, which
Mhm.
urinary retention can lead to stasis of urine, which then causes an overgrowth of bad bacteria. So there
Mhm.
are some kind of baseline things that need to be assessed and evaluated, but also, um, taking a daily supplement won't necessarily hurt anybody.
Mhm. As long as, yeah, like you said, if the D-mannose is in,
Mhm.
then for diabetics, they just need to be aware that that is a
Exactly.
sugar. Yeah. So, are there any, are there some common misconceptions about UTI prevention and treatment, would you say?
Um, Common misconceptions. I think the problem that I see a lot in patients that, let's say, develop symptoms, go to urgent care, they're just
Mhm.
reflexively given antibiotics.
Yeah.
Not every burning with urination is a urinary tract infection. Could be a sexually transmitted infection, could be a bacteria that's not readily seen in culture. More commonly, I'm seeing ureaplasma and mycoplasma, which has to be tested through a urinary PCR test, not through a urine culture,
Mhm.
um, which then leads patients to be on multiple rounds of antibiotics unnecessarily because they're not treating it appropriately or for the appropriate duration. So sexually transmitted infections, mycoplasma, ureaplasma infections. And then lastly, it could just be interstitial cystitis.
Mhm.
So interstitial cystitis is an inflammatory condition of the bladder. It's really what's called a diagnosis of exclusion, meaning you got to work everything up first and make sure it's not, God forbid, bladder cancer or true recurrent UTIs or something that's difficult to culture like mycoplasma, ureaplasma. And then you say, okay, well, I think you have interstitial cystitis. And
Mhm.
the symptoms of interstitial cystitis are very similar to a urinary tract infection, bladder pain, burning with urination, pelvic discomfort. Um, and for those patients, it's really a matter of figuring out what are the triggers and minimizing the triggers: spicy food, fried food, things with tannins, things like that.
Alcohol. Yeah.
Alcohol,
Acidic.
coffee, etc.
Yeah. Yeah.
Carbonated beverages.
Yeah, no, there's a ton of bladder irritants. No, it is concerning though to me that there are a lot of, I would say, people who are going, they're in sort of that pattern of getting recurrent UTIs, and then their doctor, general practitioners for the most part, will put them on an antibiotic, sometimes without even checking their urine, and just say, oh, do you want to try something else? This one didn't work, or just giving them an antibiotic without, maybe just doing a dip test, not culturing it to see what bacteria it actually, um, what bacteria is actually growing. So
Mhm.
the concern that I have is that, antibiotics are just being so loosely thrown out to patients with these issues. And sort of trying to figure out a way to, you know, minimize this, because I see it a ton in the support groups, like I was on an antibiotic, it didn't work. Now I'm on another one, it's still not working. What do I do? What can I take? Is there a natural way to go about this? Or is there any way to, treat a UTI without antibiotics? And you just get a
Right.
lot of questions, and people just really uncertain as to how to deal with these recurrent UTIs. So yeah, I'm just trying to figure out if there's a way we can manage it better. If
Yeah, so there
doctors
was it's a good point you make. So there was a study several years ago. I would venture to guess it was probably published 7 years ago at this point, looking at a low dose of antibiotics for 3 to 5 days versus
aren't.
no antibiotics and taking ibuprofen.
Mhm.
And patients had equivalent, and this is for young, otherwise healthy female patients who were getting urinary tract infections. And they saw that clearance rates of bacteria were equivalent among both groups. And the reason for that is the antibiotics help speed up the process of elimination of the bacteria. But it's really
Mhm.
hydration and essentially flushing the bacteria out of the urinary system that will ultimately lead to clearance of the urinary tract infection. Now, for these
Mhm.
patients that were just on the ibuprofen alone arm, it showed that really management of the bladder irritation and inflammation of the bladder due to the urinary tract infection, if you manage those symptoms, you should eventually clear the infection. Obviously, not every patient cleared the infection,
Mhm.
um, but that study always stood out at me. I thought it was very interesting, which goes to show that half the time, the primary or urgent care is giving antibiotics, and they may not absolutely be necessary. And there's also a threshold. So the American Urologic Association cutoff for a true urinary tract infection is greater than 100,000 colonies. I see patients in my office, sometimes you look at their urine culture, it's less than 10,000 colonies or 30,000 colonies, and
Mhm.
they have symptoms. Is it a true urinary tract infection by definition? No, but should you treat them? Yeah, I would treat those patients. So it's kind of one of those things where I think a
Mhm.
lot of times the primary care, if a patient's coming in with symptoms, they just reflexively give them antibiotics, because if you don't, in this day and age, you'll get a bad review. Doctor refused to give me antibiotics, or doctor said I have to come in and bring a culture as opposed to just sending me antibiotics. I think the era of patients kind of, I don't want to say having the control, but this feedback era, or it's good
Yeah.
and bad. It's you know doctors, yeah, we should be held accountable, but at the same time, we're also not a restaurant. We're
Mhm.
not, we're not a car maintenance place. It's a place where there are a lot of complexities that come into patient care, and Yeah, I read my reviews regularly and try and learn from them, but it's something
Mhm.
that I think becomes a sticking point for a lot of providers where, someone comes in, you tell them, you give them a recommendation, and if they don't agree with that recommendation, they'll write you a bad review. So
Mhm.
it's just something to be mindful of, where the primary care doctors or urgent care, they're not maybe not wanting to give antibiotics, but it's kind of the lesser of the two evils.
Yeah, I mean, I think that's also about educating people, right? Like they need to know that antibiotics are not always the right way to go and they can be
Yeah,
detrimental to your health and you
yeah,
can become resistant to them if you take them too often. And I think that, I know people who fail to have that knowledge base, understanding what antibiotics do to you and understanding, like you said earlier, the importance of replenishing good bacteria in your gut. So taking a probiotic. And
yeah.
I think people aren't aware of that. And I think that education piece is something we really have to focus on. There are people who are, there's people who go the other way and they want to avoid antibiotics even when they do have an infection that they need to treat it with, using. But yeah, that is a problem. And I think it really comes down to just education for the most
And
part.
also, not only, to your point, education is super important. I think also understanding kind of this vicious cycle that they can fall into where they get antibiotics, they clear
Mhm.
the infection, the urinary tract infection, they get a secondary yeast infection, they go on an antifungal, then they get a urinary tract infection, and it's kind of like this
Vicious
vicious
cycle.
cycle. Then they get BV, they need to go on, Flagyl or
Hmm.
intravaginal boric acid. It's really a slippery slope. So
Hmm.
um, I really advocate for not taking antibiotics unless they're necessary, and that's
Hmm.
by, culture proven necessity.
And then another thing is often, when you have a UTI, you're quite uncomfortable and you want relief quickly, and you go to the doctor, say on a Thursday, you don't get your results. Your urine goes in and gets cultured, and you don't get results till maybe the Monday or Tuesday. So what do you do
Yeah,
for the next 4 days? Do you take the antibiotic or do you wait for your actual results? That's another tricky one. So a lot of people
yeah.
are taking antibiotics, then they find out later that they have a negative um, culture. So it's
Or they find out that, by Monday or Tuesday, they find out that antibiotic they were taking for the last 4 days is, the bacteria is resistant to that antibiotic that they were prescribed. So
that too. And then they have
yeah,
to go on
I
a
see
different,
that quite
yes.
often.
Yeah.
Not
So
quite
it's
often, but I see that quite a bit, I should say.
yeah. So I'm so glad, there are, you and a couple of other doctors are now focusing on these supplements, which I think are going to be great at helping prevent people from getting UTIs in the first place. And I think, education, preventative care, all these things will help us get to a better place when it comes to recurrent UTIs. And then eventually we will hopefully have a vaccine,
Yeah,
MV140, in North America. We won't really talk about it other than it's still not available here. And yeah, as soon as we do know, we will definitely share the news. But yeah, so
um, I don't know much about the vaccine, but I do know its mechanism of action, and I know it's in Europe and I think
mhm.
some parts of Canada, if I'm not mistaken. Um,
We don't have it in Canada yet. It's for some reason North America has not approved it.
I
So
see,
people
okay.
do travel to, Spain and Portugal and the UK to get the vaccine, which is obviously financially difficult for people to just travel
Yeah.
across the sea. And um, so we're hoping that we're going to have it soon. I really do hope because there are so many people who are just really have been waiting a long time for it to come here. So
Yeah, my
hopefully.
patients as well. I think it's going to be a very fascinating treatment, and where it lies in the treatment armamentarium. Is it going to be, they go to primary care or gynecologist or urologist or all of us? I think it's definitely going to put us all in a position to hopefully help a lot of patients and keep them off antibiotics.
Yeah, that's another. Yeah, because when you think about people who are, experiencing recurrent UTIs and how often they are on antibiotics, not ideal.
I totally agree with that.
Yeah.
Totally
So
agree.
So this vaccine hopefully will be able to change that, and we'll see a lot less antibiotic use or overuse. Right?
Hopefully, yeah.
Yeah.
Absolutely.
Yeah. All right. Well, this has been really great. Thank you so much for coming on and discussing a very important topic. And I'm going to put some information also about UroDefend. This is it here. I just have a bottle here to show everyone. There's the bottle there. And we will put a link so that you can also purchase it at the bottom of the YouTube in the comment section.
Amazing.
Yeah.
It was a pleasure talking to you today, Marnie. Thank you so much for your time.
Thank you. Okay. Take care.
Be well. Bye-bye.
Bye.